Hey, it's Susan, everyone. Is anyone on the call yet?
Hi, Susan. Supervisor Ellenberg.
Yes. Hey, Paul.
Hi,
I just wanted to make sure that I got through. Okay. I'm happy to mute it until we get started. Thanks.
Okay.
Hi, this is Joe. Are others on the line, and can you hear me?
Hey, Joe, Susan, I can hear you.
Thank you.
Hi, it's Laura Rosas. I can hear you.
Good morning. This is Paul Lorenz.
Thank you.
Good morning. Yvonne Karanis, President of the Enterprise Medical Staff. I'm here to present the credentials report and answer any questions.
Thank you. We will begin at 10. A reminder to all, including myself, please speak up loud and clear. We're going to have some challenges with this system. I think we all know that. Just do what you can. Right now, I've got it on speaker. At 10 o'clock, I'll pick the phone up. A reminder as well, so please mute when you can, given the number of folks who are on the call. Okay? Hang in until 10 a.m.
So, Supervisor, I think we're ready. So when 10 o'clock comes along, go ahead.
Thank you, Dr. Smith. I will lean in at 10 o'clock sharp, since I know we have Supervisor Ellenberg at the ready, and we will begin at 10. Okay? All right, good morning. Thank you all very much. This is Supervisor Joe Smidian on the line, participating remotely. And first item of business is to call the meeting to order. That is item number 1. If we have a clerk available, I would ask that the clerk please call the roll.
Good morning. Supervisor Ellenberg?
Here.
And Supervisor Smidian?
Here.
Thank you. You have a quorum.
Thank you. A quorum having been established, we will move on to public comment. Before we do, let me just thank everybody for making an effort to participate, whether in person or by phone. I think all of us are trying to take the shelter-in-place order as seriously as we can, and we're going to have to accommodate ourselves to new ways of doing things. I know the clerk has been working hard to make our relatively old-school conferencing system work for a meeting of this type, and is working on upgrades over the course of the next couple of weeks to see if we can do even better. But thank you for that. If we have challenges today, I would just ask everybody to be patient, and please do try to speak loud and clear, and we'll rely on the clerk who is in the chambers to let us know if we are not being heard in the chambers, or anyone online if they can't hear. So that takes us to item number 2, which is public comment. Let me ask the clerk again, do we have anyone who would like to comment under public comment? I know accommodations are being made for that to happen.
We have no speaker cards, sir.
Okay, thank you very much. Then in the absence of any speakers under public comment, that'll take us to item number 3, which is to approve the consent calendar and changes to the committee agenda. Supervisor Ellenberg, there may be items that we want to move through briskly, but for now, I think if we could just get a motion to approve the consent calendar as contained in our published agenda, that would maximize our flexibility as we make our way through the remainder of the agenda. Are you comfortable with that? Could I call on you for a motion to that effect?
So moved.
All right. For the record, we have a motion to approve the consent calendar from Supervisor Ellenberg as contained in our published agenda. Let me go back to the clerk and say, do we have any cards on the consent calendar?
We do not, sir.
All right. In the absence of any public comment, then motion by Ellenberg, second by Smidian, without objection and hearing none. Item number 3, the consent calendar is approved. That takes us then to item number 4. This is a recurring item on our agenda. It is the recommendations related to medical staff and allied health professionals. Do we have someone participating who can present that item for our consideration and action?
Good morning, Board of Supervisors. This is Yvonne Karanis. I'm the president of the Enterprise Medical Staff, and I'm here to present the credentials report and answer any questions if you have them.
Thank you. Supervisor Ellenberg, any questions at this time?
I do have one brief question. Thank you, Dr. Karanis. Are there any changes to medical staff credentialing or privileges or policies that are being planned or implemented to support additional medical staff capacity across BMC or custody health for the COVID-19 response?
Yes. So 2 things that we're working on urgently right now. Number 1 is that we are granting telehealth privileges to all of our medical staff and allied health professionals to allow them to take care of patients as best as we can remotely, to keep patients out of hospitals and clinics, but still be providing the care that they need. And the second thing is that we are currently in the process of suspending our secondary site onboarding process to allow for more flexibility for physicians to move across the enterprise to different sites as we need them due to anticipated physician shortages. We are also reaching out through the Santa Clara County Medical Association to see if there are retired practitioners who are interested in volunteering were we to get to the point where we really are in a physician shortage. Although we do recognize that these may be high-risk individuals, and we'll work with them as it may not be necessarily in their best interest to be present in the hospital.
How close to capacity are we now with the number of medical personnel that's needed?
Right now, we are fine with medical personnel, and so this is all in anticipation in the next 2 to 4 weeks of a surge of patients and possible illness within the physician and allied health professional workforce.
Thank you so much. This is incredibly complicated and critical work right now, and I just want to extend my appreciation to you, Yvonne. That's all I have.
Thank you, Supervisor Ellenberg, and just a heads up to both Dr. Smith and Mr. Lorenz will probably have similar questions about capacity when we get to the item on COVID-19. That being said, Supervisor Ellenberg, motion to approve the appointments and the criteria as contained in item 4A and 4B.
So moved.
Motion by Ellenberg, second by Simidian. Let me ask the clerk, do we have any members of the public who wish to speak on this item?
We do not, sir.
Then, without objection and hearing none, items 4A and 4B are approved. Thank you very much. That takes us to item 5. This is the recurring item regarding our behavioral health services facility. Dr. Smith, I believe you are in chambers, yes?
Yes, I am.
Would you like to lead on this, or would you like to turn to somebody else?
I guess I will lead on it. I don't know if we have anybody online.
I think this is Renee Santiago. I think Paul can give you an overview status, Supervisor, in terms of the project.
Thank you.
I guess let me start before Paul gets started. You have in your packet the timeline and a description and a report. We are still functioning on the timeline that we presented at the last meeting, so that will be done in 23. And Paul, I'll turn it over to you for details.
Thank you, Dr. Smith. Supervisor Simidian. In the room with me is this is Jeff Draper from the Facilities and Fleet Department. Doug Koenig with the Facilities and Fleet, Project Manager.
Curtis Ohashi, COO of Behavioral Health.
So just to add to what Dr. Smith has stated, the timeline that is in your package, we continue to move toward meeting that obligation. The most recent activity that we had engaged in was the site selection. The county executive, Dr. Smith, has approved the site location, which will further facilitate us meeting that deadline. So we continue to move forward on the project, and the team is here to respond to any specific questions that you may have.
Thank you. This is Supervisor Simidian. Let me begin, and after I've got my questions addressed, I'll turn to Supervisor Ellenberg to see if she has questions as well or comments. The first thing I wanted to do is to note that in our packets we continue to have a timeline. I'm looking at page 2 of 4, packet page 18, that indicates design completion February 2021, construction beginning February 2022, and open to patients November 2023. And Mr. Draper, I believe I asked you and your team at the last meeting if those 3 dates were all dates we continue to believe we were on path to hit. Does that ring a bell from the last meeting?
Absolutely.
And so I'm going to ask you again today, is it your expectation that all 3 of those dates can continue to be met?
Yes.
And I asked Mr. Koenig, the project manager, the same question. Mr. Koenig,
yes.
Are those 3 dates all dates you continue to believe can be met?
Yes. Yes, they are.
Thank you. And Mr. Ohashi, I believe I asked you the same question, so I'll ask you the same question as well. Are those 3 dates still dates we think we can meet?
Yes. Yes, they are.
Thank you. And Dr. Smith, of course, I want to ask you the same question. Do we still think we can meet those dates?
Yes, we do think we'll meet those dates.
Thank you. Now, next question is, Dr. Smith, could you tell us a little bit about site selection? Because I understand we're at a different site now. Is that correct?
We have moved a little bit, and best to ask Jeff Draper to give you the details, but we tried to pick a site that we thought would be appropriate operationally and would be able to be done without much moving of services and operations, and do it as rapidly and as effectively as possible. But Jeff can give you the details about exactly what those considerations were.
Okay. Mr. Draper?
Yes, they're outlined there on package
the differences in the two sites. Site 8 in particular, the two-story garage has about 415 stalls in it. The site, if we demo that particular garage and take it down, we feel we can replace the parking and not disrupt other services, which is a real key advantage. The other thing is we don't anticipate a whole lot of unforeseen conditions at that site at this time. And we think it's an opportunity to create kind of make a centerpiece for the campus. The campus doesn't really have a center, so it'll give us an opportunity to use that facility to create a pedestrian walkway between that and the main hospital. That'll be a real advantage to, for the mental health of everybody. They'll be able to get outside and stretch their legs and have a nice space to do it in. So that's the reason for that particular site.
Okay. Let me also follow up by asking anything you want to share about the increased cost estimate, understanding that the earlier estimate was from 2018 at a different time, and if we head into different economic circumstances, the number may fluctuate yet again, but any comments there?
Of course. Well, the big thing that's happened over the course of trying to program the facility is we've learned there's a lot more outtime or programming space that's needed to support these kinds of facilities. And so it's been a 40% increase in the footprint as we are currently setting from what was originally envisioned back in 2018.
Okay. And then I know that staff was good enough to follow up on the request to look at the potential for using existing beds. From the report, we're looking at beds at O'Connor now, yes?
Yes, we are.
And Dr. Smith, who's best prepared to address the potential that O'Connor might provide?
Paul Lorenz would be able to address that.
Mr. Lorenz?
Thank you, Supervisor Committee. So we've worked with our facilities team. We're currently in the process of working with OSHPA to get a better handle on the timeline for potential renovations that could happen within that hospital. At the same time, what we were doing is looking at what's feasible from an operational standpoint. We, as an example, may be limited to children as opposed to children and adolescents, given the proximity to other services within that facility. But I can assure you that probably within the next report that we provide to you, we'll have a better handle in terms of what is feasible, both from a facility as well as an operational standpoint. And we should have a better handle on the estimated cost and the timeline.
Thanks. Mr. Lorenz, if I ask you questions where the answer is to be determined, please feel free to just say to be determined or whatever your choice of language might be. But on the O'Connor possibilities, how many, it says a suite of beds is currently vacant. What's the potential in terms of numbers of beds that might be accommodated there if we wanted to do something at O'Connor sooner rather than later?
At this time, we're looking at a suite of beds that have 24.
And could you tell the committee, excuse the interruption, could you tell the committee a little bit more about what it is that might, and I'm going to underline the word might at this point because I want to retain some optimism and flexibility, that might limit the site to children under the age of 12? I know you're aware of my particular interest in adolescent capacity.
So one would be access to these beds are within the main hospital. And so adjacent services and patients within that, on that floor are of concern. And that is why we want to, first of all, outside of the facility issues, work with CDPH on the licensing of such a facility. And so that's the primary concern that we have relative to regulatory compliance and licensing for those types of sites.
Thank you. I would just ask Mr. Lorenz and Dr. Smith if we can continue to pursue a full understanding of the range of possibilities there. I think before we ask you what you think in your best clinical judgment makes sense, understanding how we might get to other possibilities, if possible, will be important in making informed decisions. Dr. Smith, I know when we've talked about these beds before, you've been, if I'm remembering correctly, relatively confident that they'll pay for themselves if we can just get the facility in place. You share that view or continue to have that view with respect to a possible suite of beds at O'Connor, and particularly if they were limited to children under the age of 12?
Well, Supervisor, the COVID crisis and the activities going on at the state and federal level have put the financing for healthcare into a big question mark. And so I don't feel quite as confident that they'll pay for themselves, but I do feel confident that we need to do it. And we will be pursuing every effort that we can to make sure that we get paid appropriately for those services. The federal government still proceeds with the so-called MFAR, which you'll get a report on in a little bit from Renee, but that's an effort to try to reduce funding for Medi-Cal, which will then subsequently reduce funding for what used to be called short dwell and is now specialty Medi-Cal for behavioral health, and that would have a negative effect. We'll see if that proceeds, but either way, we will move ahead.
Thank you. I know, or at least I think I know that we don't have the benefit of Ms. Tully's participation this morning, but is it your expectation that if we were limited to youngsters under 12, that there is sufficient demand for these kinds of beds and these kinds of services for that age bracket, that it would still make sense to go forward, assuming we can make the economics work, obviously?
Yes, we would have to obviously attract regional participation because within the county itself, I don't think that we would have sufficient numbers, but there's no paucity of need. So I'm sure that the service would be quite well utilized.
Thank you. Why don't I turn to Supervisor Ellenberg and see if you have comments or questions, Supervisor?
I have no comments or questions on this item. Thank you.
All right. Well, then I thank Dr. Smith, Mr. Lorenz. Anything else from you or your team? Mr. Draper, I'll go in order. Dr. Smith?
Nothing.
And Mr. Lorenz?
No.
Mr. Draper, anything else from you or your team?
Nothing at this time.
Okay. Then I will say thank you, and we do have the item agendized simply for purposes of receiving the report. So if I can ask my colleague, Supervisor Ellenberg, for a motion to receive the report.
So moved.
And I will second, I want to confirm with the clerk that we don't have any speakers on this item.
We do not, sir.
Thank you. Then in the absence of speakers and without any objection, the item is deemed received. That will take us on to item number 6, which is to receive the report from the Public Health Department related to COVID-19. Dr. Smith, since you are present and these are folks working with it for you, why don't I ask you if you can orchestrate the initial presentation before Supervisor Ellenberg and I go to questions and or comments.
I think at this time we have Sarah Cody online who can give you a brief update, and after she's done, I have some numbers for you to talk about.
Thank you, and I know we also have Mr. Lorenz on the line, obviously, and Supervisor Ellenberg, and for anyone else who may be listening or participating, I know that both Mr. Lorenz and Dr. Cody were prepared to be physically present in the meeting, and I asked Dr. Smith to please assure them that we could make this work telephonically in our continued effort to make sure we really were doing as much as possible to let people both shelter in place and respect the social distancing request. So, Dr. Cody, we turn to you. Thank you for your work, and what would you like to share with us this morning?
Thank you, Supervisor Simitian and Supervisor Ellenberg. I am calling in from a remote location. and I will provide a brief overview of where we are. Just to put this into context, we are now in week 8 of our response to COVID-19. Our Medical Health Joint Operations Center and County Emergency Operations Center remain fully activated. And the work at hand right now is integrating our operations as the scale of this moves very quickly. At the same time, we're working very hard to ensure that we can practice social distancing to the extent feasible to protect our operations. So I'm just going to give you a brief stat report. This is at 5 p.m. last night. I want to tell you that we are in an exponential growth phase. Santa Clara County is the epicenter of the COVID-19 outbreak in the state of California. What we're seeing now as our case counts and deaths begin to rise probably reflects infections from, say, 2 weeks ago. As of last evening, our case counts, and I believe this will be posted on our website shortly, we are at 175 cases with 6 deaths. About 70 of these cases are presumed community transmission. The remaining are either close contact related to travel or incompletely investigated. It's becoming, I think, less important to clearly understand the type of transmission because I think we can now safely say that community transmission is fairly widespread. The acuity level of our cases remains high, and that reflects the fact that that's still where we're doing a lot of testing and confirmation of cases. I'll just give you a very, very brief overview of our response. In addition to scaling our case and contact investigations, trying to scale testing, which is mostly going to be decentralized by commercial and academic labs. My role has been to think very carefully about community mitigation and what I can do as health officer. And so just to review, I've issued 3 health officer orders in just over a week. The first order I issued on Monday, March 9th, which was to limit mass gatherings greater than 1,000. As we saw the epidemiology change, the following Friday, the 13th, I issued an order to limit mass gatherings greater than 100 with certain restrictions on gatherings between 35 and 100. On that same Friday, Friday the 13th, just last Friday, all schools in our county closed. That was a decision by all of the superintendents in the county working together under the leadership of Dr. Dewan. Over this past weekend, in conversation with colleagues around the Bay Area, I issued our 3rd health officer order, which mirrored identical orders issued in the core Bay Area counties. This order established the most stringent and far-reaching restrictions that have been issued to date in the country as far as I understand. And in brief, they direct everyone in our county to shelter at their residence, to minimize operations of all non-essential businesses. We prohibit gatherings of any size and prohibit all non-essential travel. We did allow a number of exceptions with the goal to enable access to health care and other essential goods and services such as groceries, pharmacy, and services that people need to maintain their home environment. And we also, of course, permit essential government functions and have language around social distancing. I think that the amount of work and communication needed is vast. It's almost deafening. We have a few areas of priority work ahead, and they include ensuring our healthcare system capacity in the county, mitigating the economic and social impact of this order, and maintaining our nimbleness to accommodate that incredibly rapid change in the type and scale of work that we need to be doing. I want to say, and I want to close with immense gratitude to everyone who has been working on this. I would say confidently that our county, as difficult and chaotic as it has been to do this work, I feel that we're one of the most well-situated counties to respond, just because of the tradition of work that we've done together, the excellent relationships that we have, and the phenomenal cooperation, compassion, and professionalism of every single person who's working in our Medical Health Joint Operations Center and Emergency Operations Center. And I also want to again thank our federal partners from the CDC who have been embedded in our operations since late January and have been absolutely invaluable. And I will stay on for a little bit to answer as many questions as I can, but I want to say that I may not have answers to all of your questions, but I will do my best.
Thank you. Supervisor Ellenberg, I'm going to go to you first if you're ready to engage here. I've got a lot of questions. I'm guessing you do too, and I'm guessing that some of our questions will overlap. So why don't I start with you if you're good with that?
That's great. Thank you. And I have just 3 or 4. First, Dr. Cody, I just want once again to thank you and to express my tremendous admiration and appreciation for the incredibly hard work that you are doing, and want to acknowledge that all of our county leaders and partners here are really challenged because we're responding on behalf of the whole community through EOS, the county departments or organizations that our employees represent, and of course, all of your own families as we try to adapt to this unprecedented crisis. So I do, as I said, I have 3 questions, and I will be brief and succinct. First, can you please provide an update on the current testing activities, including the launch of the Verily mobile testing operation, the public health lab, and the local hospitals and providers, and touch on any methods of coordination that are in place across these different resources?
Certainly. So, as I think I've mentioned before, our public health lab, of course, was the first lab to come online. Our testing capacity is not vast, and public health laboratories in general are not designed to scale testing. They usually behave as reference laboratories. So our public health lab continues to test the highest of the highest priority specimens, which includes, but are not limited to, specimens coming from hospitals, patients who are in the intensive care unit or hospitalized, and then specimens, for example, that would be of public health consequence, such as someone in a long-term care facility exhibiting symptoms. The way that testing is getting essentially scaled and decentralized, Stanford has been a partner in testing. I don't know I can't tell you numbers as far as to be able to describe the scale of testing that they're able to do. And then we have a point person on our team working with Verily. That's the Google-related company that's enabling drive-through testing, and that, I believe, was initiated yesterday. And we...
Billy needs a list right now.
Excuse me.
Pardon?
We've got some crosstalk on the phone. If we could ask folks to be careful with that, I'd appreciate it. Let's go back to Dr. Cody as she responds to the question from Supervisor Ellenberg. Dr. Cody, go right ahead, please.
Basically, just an overview of the lab testing is that we're still attempting to scale, but I think the important take-homes, and I don't know where I left off, is that the public health lab is still focused on highest priority testing, including patients who are hospitalized or in the ICU, and working with partners to scale and decentralize testing. And the major partners are Stanford and Verily. I don't have numbers on the number of tests that those sites are running.
Let me add a little bit to the answer in terms of the question that people tend to have is, where can I get my test if I'm concerned but I don't fit the criteria of being ill or being in the hospital? And the answer to that is that you should contact your healthcare provider, because as Dr. Cody points out, the community access to testing is decentralized. Not all tests are the same. We in the public health department are limited to the CDC testing kits and the CDC criteria. Places like Kaiser have their own priority system. They're doing some drive-in testing, but only for Kaiser members. They do not have a responsibility to coordinate with the county, and their only responsibility is to notify us of positive tests, which they have been doing, but they don't notify us of the scope of how many tests they have been doing. They do tell us what their priority testing is. The Verily testing started in San Mateo and in Santa Clara at the fairgrounds. The test has actually been developed by Quest Laboratories. It's a different test than the CDC provides. Again, they have developed their own criteria in conjunction with the governor's office and the CDC in order to be considered for testing at Verily. You have to go online to projectbaseline.com. So all one word, projectbaseline.com. You'll have to sign in. They give you a questionnaire. Excuse me. A questionnaire that you have to go through, and if you qualify, they'll give you an appointment at one of the sites. The testing at these sites is only done by appointment, only done through Verily. Again, they have responsibility to let us know what positive results are. They don't let us know how many they're doing. And there are other private labs that are coming online with their own tests. So there are really 4 or 5, actually worldwide, about 7 or 8 different tests that are available, but all with different criteria. And since they're private sector laboratories, they're being manufactured, and the testing is being done in their private labs. So we at the county only have access to the number of positive tests and the location of the positive tests in our county. And we are discussing at the state level, trying to expand the authority of the public health department to get more information from the private sector regarding these tests. So I think I'll turn it back over to you, Supervisor Simidian, for further questions.
Sure. Why don't I go back to Supervisor Ellenberg, and I'll circle back on some of these things after we run through. Supervisor Ellenberg. Thank you, Dr. Cody, and thank you, Dr. Smith. Go ahead, Supervisor Ellenberg.
Thank you. That really is helpful. I understand why the information can't be complete on testing, but it's good to give us a sense of where we're going and how this is expanding. We talked about kind of related to testing. My second question is about surveillance. We discussed testing for surveillance purposes at prior meetings. What surveillance methods are in place currently for corona or flu-like illnesses, and what do they tell you, Dr. Cody, about the extent to which coronavirus is circulating in the county?
Thank you for your question, Supervisor Ellenberg. We had several different types of surveillance that we had stood up. One had been looking at absenteeism in the schools. That surveillance system obviously can no longer function since our schools are closed. We also had, just to step back, our question 2 weeks ago was very different than our question today. And our question 2 weeks ago was, what is the extent of community transmission? Is it limited or is it widespread? I think we've answered that question, which is that community transmission is widespread, and we've taken the action, which is to ask everyone to shelter in place. And so, to some extent, those questions are somewhat moot. It's widespread. So we have ways where we're still trying to monitor broadly to understand the scope and the magnitude. And as Dr. Smith was mentioning, I think that being able to get both the positive and negative results from laboratories that are testing will really help us to track, because then we would have a positivity rate. And that could be very important surveillance information for us.
Yeah, it certainly does seem to be. If we don't have a denominator, it's hard to know what the number of positives means. My last question, maybe for you or maybe better suited for Paul, but I'm asking for both VMC and the hospitals across the area. What is the current status of available beds, ICU beds, supplies, and staffing to be able to meet the potential increases in patient volumes, and what efforts are underway to address any projected needs?
Paul, let me jump in with some data here. I have the ICU count from this morning, and as Dr. Cody pointed out, these numbers change pretty dramatically from hour to hour, but I'll give you what I have. We have, this is just related to ICU care. Paul will talk about other capacity and supplies, but we have in the county 9 general acute care hospitals. We have theoretically 284 ICU beds among them, but that's just physical beds. That doesn't mean staffed beds, so you can generally decrease that by 5%. Currently, we have 68 confirmed COVID patients in the entire hospital bed list. That's not just ICU, that's all beds. In the ICU, there's 29 out of the 284 that are COVID positive. 23 of those are on ventilators, meaning they're exceedingly sick and we're having to breathe for them. Those 23 are extremely at risk for bad outcomes. And in terms of available ICU beds, there are currently 39. However, there are some critical problems. Regional has none available out of 34. St. Louis has none out of 8. O'Connor, 1 out of 22. Stanford has 10 out of 66. El Camino, 2 out of 24. So we are, as a integrated health system throughout the county, quite at risk if the numbers increase even slightly. That will put the ICUs into major trouble situation. So, Paul, maybe you can give an update on other bed issues and supplies.
Excuse me, this is Supervisor's Committee, and before Mr. Lorenz speaks, Dr. Cody, you're still with us, yes?
Yes, I am.
Dr. Cody, I want to take just a moment here to pause on Dr. Smith's data sharing. My understanding is this is the reason, or among the reasons, why you have been so clear about the need to, quote, flatten the curve, to slow the growth. because absent our ability to flatten the curve and slow the growth, we worry about the capacity of the system, as Dr. Smith just described, to accommodate the numbers we might see. Am I on point here? Permission to speak freely, Doc.
Supervisor Smidian, that is exactly correct. I think one way to think about this is that, I'm sorry, I'm at home with a barking dog. We are traveling very fast on a high-speed train, and there's a curve in the track that's coming up. And if we don't slow this train down with everything we've got right now, we are going to derail. So that is exactly the reason behind not just my health officer order in Santa Clara County, but that is the reason to have a unified approach for the region. So we're ahead of where our adjacent jurisdictions are, but they have the benefit of looking at where we are in our county, and if we can all slow it down together, then we can preserve our healthcare system capacity across the region.
Got it. But again, and I know, part of the challenge is that there's so much information coming so quickly, and much of it, of course, is changing. But I'm not sure that the message has gotten through crisply to the public that absent some real rigor and discipline around the social distancing and the sheltering in place, the system could be overwhelmed in relatively short order. And that's why we all need to take it seriously. Thank you. I'll just let that go and then go on to Mr. Lorenz if he can remember what the question was from Dr. Smith before I interrupted.
Thank you, Supervisor Smidian and Supervisor Ellenberg. First, I have to say that in all that we're doing, communication between the county EOC and, of course, the Public Health Department has really helped the hospitals in our efforts to plan for the increase in demand on our system. Probably the most effective messaging that has gone out, and it went out early, was around the fact that we wanted the public to understand that only come to the emergency room if you're acutely ill. And what I can report to you today that our ED volumes at our 3 hospitals are down significantly. So those patients that are presenting are acutely ill. Approximately 28% of those presenting have influenza-like symptoms. And we are testing those that meet the criteria set forth by public health. The other thing that I would share with you that hospital bed capacity. So we've been very fortunate that we do have bed capacity both at our medical surgical level as well as our ICU level, both at O'Connor and Valley Medical Center. St. Louis is impacted because it is a smaller hospital, but we are able to manage those patients as an enterprise to ensure that they have the available beds for the South region, South Bay community. In general, what I would say to you, and I know Supervisor Smidian, you're always interested in numbers. So as a system now, with the acquisition of the 2 hospitals as part of our system, we have about 1,000 plus general acute care beds within our system. 200 of those beds can provide ICU ventilator-dependent care. That is really related to our available ventilators that we have. So outside of our ICU beds, we will be able to ramp up in terms of our ability to manage patients that present with COVID and require ventilator level of care. Again, that's 200 that we can ramp up as a system too. With the provision of additional ventilators that we can get either through the county EOC, through the national stockpile, we would be able to then accommodate from a facility standpoint additional bed capacity for ICU level care and ventilator-dependent patients. And I can share with you, and actually Joe Cafaro is here with me, as a county in working with all of the other hospitals. All the hospitals are looking at their surge plans to ramp up to be able to provide that level of care within their facilities. And right now I know that CHA is working with us to make sure that we have a clear idea of each hospital, respective hospital surge plan capacity, like the ones I just want to explain for you for Valley and the county system. But what we are also planning for is that if we go beyond our facility capacity as hospitals in this county, we are looking to alternative plans to provide for a situation where we are overwhelmed. So with that being said, I'm happy to answer any additional questions that you may have.
Ms. Ellenberg, I want to defer to you. This is still your question, and then I'll step in if I have additional questions. Go ahead, please.
Thank you. I'd actually like to hear from Joe Cafaro if there's an update that you want to share or something that you'd like to add to this piece. I think it would be helpful to hear a broad countywide perspective. I mean, countywide beyond the county organization.
Where to start? Hello, this is Joe Cafaro with the Hospital Council. So thank you very much for having me here. So I would like to reiterate what Paul had said, is the work and the guidance we've been getting from the EOC and from public health has been wonderful, and we've been working together and very well. The collaboration that Paul had mentioned, that we're looking into each of our hospitals to see what is possible surging, is going on, and we're doing that work together right now. I don't think I have anything else to add right now regarding that specific issue. I have other things to update you on, but that could be done a little bit later.
Okay, back to you, Ms. Ellenberg.
Oh, okay. Thank you. I think that answers. It does answer my questions. I mean, I'm hesitating because it really is a huge worry about the bed capacity. But Supervisor Smitty, and I'm sure you have more to ask, so I'll listen.
I do, and what I'll try and do is begin with some of the issues that have already been raised. And Supervisor Ellenberg, please, when I wrap up my questions, feel free to come back if that's prompted additional questions, follow-up questions.
Thank you very much. I appreciate that, Supervisor. Thank you.
Mr. Lorenz, you mentioned a couple of things that I wanted to just tease out a little more information on. One was emergency plans if we hit our capacity. Thank you. It was helpful. I understood you to say that while the ICU beds are our first line of defense, that we had some additional capacity with the 200 of the 1,000 beds that could accommodate ventilators and provide that sort of acute care level below ICU, but over and above what would be available in a, quote, regular bed. Did I get the medicine right there, more or less?
Yes, that would be 200 ICU beds total. That is correct.
And that's over and above the 284 that were initially referenced in the 9 hospitals that I know are outside our corporate entity of the county, yes?
I just want to be sure I'm clear. So, and thank you for asking that question. So the 200 are specific to the county hospitals.
Right.
And that 200 is inclusive of our current operating ICU beds.
Thank you.
Which we currently have approximately 90. So we're talking about an additional 110 ventilator bed capacity.
Got it. No, thank you. That's very helpful and clarifies. A little confusing jumping back and forth between our own County of Santa Clara numbers and the county-wide numbers, and then I'm afraid I made it even more confusing by conflating the two. So thank you. That's a helpful clarification.
Supervisor, could I just jump in?
Please.
The numbers that I gave are beds that are currently set up for ICU care, and what Paul's referring to is there's another 120 rooms, beds where we could expand ICU care, and all of the other hospitals have the same capacity. The numbers I gave you were just what's currently up and running.
Got it. Thank you for that. And then I heard a couple of specific references to ventilators and the ability to get those from other places. Can we get them? This has been an issue that I know that the popular press has started to pick up on, the question of whether or not sufficient numbers of ventilators are available and specifically available in our area. Who'd like to comment on that?
So this is Paul Loren. So obviously we're looking to all sources of additional ventilator beds, including further acquisition should the companies have them available. We are also working with the county EOC so that we can look to the state or the federal stockpile, national stockpile, because we do know that they also have ventilators available at both levels.
Are you currently feeling like if we have a legitimate need for the ventilators, they'll be available? I know that's a hard thing to assess, but it seems like a critical question in your planning.
It is a hard question to answer at this point in time.
All right. You mentioned emergency plans as well, Mr. Lorenz. Does this involve surging with tents? What do those emergency plans look like over and above the ability to convert some of the, quote, regular beds to ICU operations?
So what we are looking at in coordination with the other hospitals are existing facilities that may be able to be converted to accommodate beds. We are looking for other facilities throughout the county that would have not only the equipment but the supplies, i.e. surgical centers. And we're working closely with the Medical Association and, of course, CHA on that. The tent, if worst comes to worst, we may be looking at tents, but we would look for facilities, constructed facilities first to accommodate that.
Okay. Question for Dr. Cody and then Mr. Lorenz and Dr. Smith as well, if they'd like to chime in. One of the questions that my office and I have been getting from people is, well, if the testing is no longer really about what I'll call conventional public health identification, containment, isolation, contact tracing, what is the value or importance of getting tested at this point? And my understanding is that it's so that individual patients can be treated in some way, but there seems to be quite a lack of clarity about, well, what happens if you are in fact identified with COVID-19? What can healthcare, medical systems, your doctor do for you, if anything? So could somebody give us an answer to that question, please? And I'm going to start with you, Dr. Cody.
Thank you for the question. I think now we're moving to a phase where the most important message to get out is that anyone who is ill with symptoms of an influenza-like illness, it may or may not be COVID-19, but anyone who is ill must self-isolate. It would be ideal, of course, if we had testing that was decentralized and widely available so that people could confirm whether they are ill with COVID-19 or not, because it might assist in their behavior change and ensuring that they are meticulous about isolating and not infecting others. But there are some other challenges with testing, which is that just as there are issues with supplies of personal protective equipment for use in healthcare facilities, there are also, we're beginning to see issues with supplies of swabs and the viral transport media. So in addition to the capacity of labs to run the test, there's going to be issues with the materials necessary to collect the specimens. That might be another variable that limits widespread testing. So the message, loud and clear, is If you're ill, you need to stay home, period, full stop.
That being said, and understanding the criticality or the importance of that for the containment or the flattening of the curve that we've discussed previously, if you're a 60-year-old and you're identified as having the COVID virus, what can your doctor do for you? In some cases lethal, in most cases not. Are there things that I think people are trying to understand? So there isn't a vaccine. Is there a, quote, treatment? Is there a cure? Are there protocols that somebody who's identified having COVID-19 should be following to get healthy again? Or is it just, I don't think we're going to tell folks that, some of you will make your way through it, some of you won't. So what's the, and if there are gaps in our knowledge, that's certainly fine to acknowledge. But that's the question that I'm starting to get, my office is starting to get now that we've gotten to this point in the crisis.
So we are public health, across the country, and I think this may even be somewhere on the CDC website. I'm not certain. But with testing, when people get a positive result, the idea is that they will have instructions, and we'll push it out in many other ways with, you're positive, self-isolate at home. These are the triggers to look out for when you need to call your physician or seek care. But as much as possible, the idea is to have people who are infected not interacting with the healthcare delivery system, because we don't want any more disease spread within the healthcare delivery system. So that is really important. As far as treatment, at this time, it's what we call supportive care, which means that if you're ill enough to require hospitalization, you might need support, as in you might need oxygen, you might need support for your blood pressure or other things like that. There are a few drugs currently being used under a compassionate use protocol, so they are there's some evidence that they are effective against this virus, but of course, there hasn't been the usual widespread trials and evidence, but they are being used under a compassionate use protocol, and much of that is being coordinated by the CDC, so that when we have patients in our county that might require one of these drugs, we work with the Centers for Disease Control and Prevention and ensure that patient gets this particular therapy.
The supportive care is presumably for folks who are at a more acute level. Did I grasp that correctly?
That's right. That's if you require hospitalization.
And the supportive care, forgive me for putting it just as bluntly, presumably could make the difference between someone who makes it through and someone who does not. Did I get that correct?
Right. One of the reasons why it's so important to slow down the spread of infection as quickly as we can and preserve hospital capacity is that we can prevent death by ensuring that people who are critically ill and need a hospital bed have a hospital bed.
And again, Doc, I know you're taking this from the public health standpoint. I'm trying very much to focus on the understandable individual concerns people have about their own health or those of a family member. And I'm trying to find hope where there is some. So that supportive care can, in fact, keep someone alive who otherwise wouldn't make it through the COVID virus, all other things being constant, but for the supportive care. Yes?
That's correct.
Okay, thank you. That's the piece that is helpful for me to be able to share. Dr. Smith and/or any others, we haven't touched today on the concerns about transmission in our jails, which seem a very challenging environment. It's sort of the opposite of self-isolation, and also with our homeless community. Could you comment on approaches that are being taken in those two very different settings?
Yes. Let me follow up a little bit on your previous question to Dr. Cody, and then switch to the jails and the homeless. One of the major frustrations that the community has is that we're so far behind the ball on a national basis. And I think the analogy to use is the routine yearly flu. In that situation, we have a virus that begins to spread in Asia at a time period much earlier than when it gets to the United States. And at that time, testing is done. The virus antigens are identified. The antigens are the receptor sites on the virus that are susceptible to antibodies. And because of that, there's a effort and a decision made to create vaccines that are effective against that particular set of antigens. So when you go into the doctor's office and get your vaccine during the regular flu season here in the United States, there's already been a long process of identifying the virus, testing the virus, testing the test for the virus, testing the vaccine, and coming up with some prediction of how well that particular vaccine will do. None of that happened this time. The virus was identified in China, and as a world, we were way behind in identifying the antigens in the virus and the particular options for vaccination. So there is no vaccination now, although laboratories are rapidly working to try to find a vaccination. And in terms of treatment, specific medical treatment for the flu, we've all heard of Tamiflu, which is a drug that was developed over many years that has a direct effect upon the virus but doesn't prevent the flu. It mitigates some of the symptoms. None of that research has obviously been done with COVID, or I should say SARS, CD, which is the virus. So in terms of specific treatment, it's highly unlikely we'll get there anytime soon. But people, as Dr. Cody says, in different parts of the world are using some drugs that don't really have evidence and haven't been tested. And that is what you read about, for example, in some of the Far East countries. In terms of treatment here in the United States, there isn't any specific treatment. The one positive thing that people have to think about is that 80% of those who get the disease will have minimal or moderate symptomatology. At least that's our best estimate at this point. So it's not in any way a death sentence. The problem is that it is very serious disease for the other 20%, and we find statistically that there's a much larger effect on older populations. If you're under 50, your risk of mortality is extremely low. Over 50, it begins to accelerate to be extremely high, and at 80 plus. So it's really, at this point, a disease or disease process that affects the older generations most dramatically. So for most people, it will be rest inside and keep away from others. For some people, it'll be hospital care.
Dr. Smith, again, and I apologize for pushing on this. Maybe I was not as blunt as I needed to be, but just, for the 20% of folks who are presumably most concerned, there are things we can do to improve their chances of making it through an episode of COVID-19. Yes?
Yes.
Thank you. I understand that with all those limitations that's a qualified yes, but I think, again, because there's so much information coming at people so quickly that, some of the questions we're getting sort of suggest like, well, why should I care? It sounds like, if my number's up, my number's up. People have been pretty dark about some of this. And, what I'm trying to clarify here is that the reason we're talking about the ICU beds is because there are, in fact, the supportive care that Dr. Cody referenced that can, in fact, help folks who are identified with the virus if they get to that level of concern. Am I still rephrasing accurately here?
Yes.
Okay. So back to the issue of the jails and folks in our homeless population. Let's start with the jails, where, as I say, we've got people obviously in close proximity with each other. What's our situation there? If anyone is prepared to speak, I know that this is not an area where we usually have corrections staff in the conversation, but is there anyone who can share any information?
Yeah, I can give you an update. The jail has had yearly a flu protocol in place where people are screened at intake for the possibility of flu and then isolated as much as possible in the jail when they need to be incarcerated. Obviously, they also have, as part of the program or part of the protocol, to release as many individuals as possible at booking who are ill. So they're using essentially the same protocol because it's basically the same: identify individuals with symptoms and or fever, and either release them, referring them to medical care, or if they're severely ill, transferring them to appropriate location, emergency room if necessary, or if they have a severe offense, putting them in the jail with appropriate distancing. At this point, we don't have any identified individuals in the jail with COVID. We have had a couple of people who are concerned about exposure, but no positives. And, we're obviously really concerned about that. At the same time, the sheriff has implemented a program which sheriffs are allowed to do to release individuals from jail with low-grade nonviolent offenses early in their sentence, and we think that we'll get up to about 200 individuals who can be released. Or also the courts and the DA and the public defender and the sheriff are working on programs to prevent incarceration through the courts and utilize monitoring in the community. So all of those efforts are trying to keep people out of the jail and get people who are potentially sick away from the jail and still protect the public welfare. One of the last things that I will talk about that we're thinking about at this point, it hasn't been yet, having to do with incarceration. At booking, if the person is being booked for an offense that has a bail below a certain number, they are released on their own recognizance. And local jurisdictions have the discretion to decide what that number is based on what the offenses are that have that standardized bail, because each local jurisdiction has its own bail rates. We're thinking about increasing it if we can be assured that that will not result in any risk to public safety.
Thank you. Can we shift over to our homeless population in the county?
I think maybe I'll turn that back over to Paul Lorenz.
Thanks, Mr. Lorenz. We got somewhere between 7,500 and 10,000 folks out there who are part of our census, and what's our thinking about best practices and what are we able to implement and what are the challenges?
So thank you, Supervisor Simitian. So the homeless healthcare team is, as mentioned previously and reported previously, are working in the large encampments to ensure that if there are individuals that have influenza-like symptoms, that we're testing for not only flu, but then COVID. And then in those situations, we're going to be aggressively taking action to make sure there's no further exposure given their housing situation. So that's one. The second thing that we're doing, obviously, is trying to get as much communication out about what's going on generally with COVID and the community-wide transmission that's now occurring in our communities. I'm happy to answer any further questions, but I do know that we are actively working with many organizations to try to get the word out.
Thank you. A follow-up on the homeless community. We've got what would appear to me to be a bit of a catch-22, which is we're encouraging people to find shelter where they can. On the other hand, if we put people together in shelters, that raises some social distancing challenges. How do you square that circle, for lack of a better way of asking the question? Do you understand the question I'm asking?
I do. And obviously, I think you're asking that question because it's a very difficult thing to do with this population. So, to the extent possible, we are trying to provide as much guidance and as possible. I would also share, and this is something that's important to understand, if an individual comes into one of our clinics as well, because I think in many instances, because we have such a good relationship with this patient population, and they do have influenza-like symptoms. Again, we're testing them, but we're also working very closely with the Office of Supportive Housing to make sure that they can be housed and accommodated. And we've had many instances in working with public health and working with Office of Supportive Housing in getting them into the appropriate setting, so not to further expose patients. And I have to say that's been a very well-coordinated effort, not just with the Office of Supportive Housing, public health, the healthcare system, but also with the County Emergency Operations Center, because in a lot of respects, what happens is that when people have nowhere else to go to get direction, they are able to get through to the county EOC to ensure that we don't have any further problems within this community. So I can tell you everyone is focused on the very issue you're speaking of, because we know that it is a very difficult population to manage.
All right. A couple of very specific things, and I'll try and do these more quickly and ask responders as well. Popular press reports, I see some kind of linkage or connection between COVID-19 and pneumonia popping up more and more. What's that about, Dr. Cody or anyone else who can comment?
Supervisor Smitty, I'm sorry, I don't quite understand your question.
Well, let me ask the question just very directly. What relationship, if any, is there between COVID-19 and pneumonia?
COVID-19 is a cause of pneumonia.
And so does that mean that we expect a spike in the number of cases of pneumonia?
Yes, that's part of the reason for ensuring our hospital capacity in ICU beds is to take care of people with severe pneumonia, severe respiratory symptoms.
Okay. As I say, it has been popping up in the press a little bit more. Mr. Lorenz, Dr. Smith, anything else on that before I go to my next point or question? Nope.
No.
Dr. Smith, you don't need to respond today, but we have a board meeting scheduled for the 24th of March. I would just ask that if, given the nature of the public health crisis, and I know there's broad authority in state law for our public health officials, but if there is delegation of authority others in the organization need, this might be a time when it could be considered and, if appropriate, granted. As you know, I tend to be a little skeptical about broad delegations of authority, but under the circumstances, I just want to make sure that we don't miss that opportunity to provide it. So with everything else people are obliged to be thinking about now, I just wanted to ask if you could give that, you and your team could give that some thought between now and the 24th, and perhaps more critically between now and the time when you can last possibly put something on the agenda for the 24th. Okay?
Surely.
On staffing, I'm just going to make a passing mention. We haven't talked about seniors today, by the way, but I know that there is a special concern there and that we're taking special action. And I'm just not asking the question not because it's obviously not important. It is important, but I feel like I've been kept informed on that. Staffing has been a concern in terms of healthcare professionals, and when we talk about child care, again, I think for members of the public, the linkage with the ability to provide appropriate and robust healthcare response is not always obvious, but it certainly is for us. Where are we on making sure that we are not losing staffing capacity by virtue of the fact that we have limited child care options? And that may be one where we want to first hear from our county organization, but then also pull Ms. Cafaro back into the conversation if she thinks that would be timely.
Okay, I can give you a little update on that. One of the deputy county executives and team, Leslie Crowell, is working on contracts currently in order to provide child care for children of our essential workers, which includes obviously nurses and staff and doctors at the hospitals, but also includes other essential workers throughout the entire county, fire, sheriffs, social services, government functions. Essential workers doesn't, in this situation, just mean people who do health care. It obviously means keeping the functions of government alive and well, and being able to comply with all the rules and regulations as best we can. The contracts are currently being developed and finalized. Supervisor Ellenberg has worked with Boys and Girls Club and YMCA and others to get those, get us the information to get those contracts going. We're also out surveying other providers, looking at gymnasiums and other areas where they have had child care, but because of the shelter in place, they might not actually be utilizing it at this point. So we're working on that, with the highest priority being our essential workers first, and then looking at other workers within the county government and other county facilities, county-wide facilities.
Okay. We obviously, I thought it was helpful and important that there was reference earlier in terms of the county-wide response to hospitals that are not part of the Santa Clara County or County of Santa Clara county organization as being critical partners of a larger response system. In the North County area that I represent, I'm assuming that includes Stanford Hospital and El Camino and Packard, yes?
Right. This obviously hasn't expanded completely yet, but that's our goal. Maybe Joe can give more information on what those hospitals are doing themselves, but we consider all of the 9 or 11 hospitals as part of a system, so we want to make sure that they all have functionality.
Thanks. Ms. Cafaro?
Yes, hi, good afternoon. Thank you. So currently, several of the hospitals are standing up child care centers. They are working with their local nonprofits. For example, I believe El Camino will be looking with the YMCA and working specifically since they have them adjacent to their property in Mountain View. In addition to that, some of the other hospitals are actually giving financial assistance and helping to pay for daycare workers and babysitters for individuals who are able to do that. We through the help with CHA, we've been able to streamline the waiver process at the state with DSS to be able to help individual hospitals and other health systems to be able to maneuver that process in a quick manner.
Got it. Ms. Cafaro, are we communicating, cooperating, collaborating, all those good things between the county system and the child care conversation there and the folks who are independent of our county and the child care situation there? Is that happening?
It is starting to happen, yes.
All right. Well, for all parties, at the risk of stating the obvious, this is one where we're all in it together. So, Dr. Smith and others, from my standpoint, healthcare demands that can't be met in one place end up moving to another place. So it's in everybody's interest to make sure that folks are fully staffed in every hospital and every clinic to the extent that we possibly can. I understand our effort for county facilities per se, but again, if it's part of a larger system, we need to be doing whatever we can to make sure everybody gets the support they need to take up the greatest possible share of cases that they can address. I think I will stop there and say, Dr. Cody, anything else that you want to share at this point? We've covered a lot of ground this morning. It's been a long conversation. Thank you.
I think that's it. Thank you so much, and I'll sign off if there's nothing more.
Okay. And Mr. Lorenz?
Yes, Supervisor.
Anything else? Dr. Smith? And I want to go back to Ms. Ellenberg. I hope we haven't lost Dr. Cody. If she's still there, if we have, we'll ask Paul Lorenz and Dr. Smith if they can respond.
I should have mentioned one other thing about the homeless population. We have, as the board knows, we're in the process of purchasing 2 hotels that we were initially going to use in general for homeless population. We've been now repurposing that to focus on homeless individuals who need isolation. So we don't have great capacity at this point, but that's an effort that we're working on vigorously.
Thank you. Ms. Ellenberg, I apologize if we lost Dr. Cody here, but any other questions or comments at this point?
That's fine. I didn't have a question for Dr. Cody. I just want to make sort of a wrap-up comment and then also address in a little bit more very quick detail your questions about child care. First, just generally wrapping up this whole presentation, and this is sobering and really drives home the need for adherence to shelter in place. And Dr. Smith, Paul, anybody, as there are additional steps that we can take to assure people that they need to understand the critical importance of sheltering in place, let us know so that we can push that out as well. And I think that there is still some need to clarify any confusion amongst businesses or organizations as to whether they are exempt. So those don't need an answer, just pieces to keep in mind as we work on our external communication. And Joe Simidian and Joe Cafaro, since the weekend, there has been a lot of work building with a variety of partners to provide essential worker child care, from Boys and Girls Clubs in Cadango to the JCC in Palo Alto, First Five, the County Office of Education. And as fast as the county can help us get contracts signed. There are numerous providers that are standing by ready to welcome kids.
All good. Dr. Smith, anything else, or is it time for me to ask for a motion to receive the report from Supervisor Ellenberg?
Time to ask for a motion.
All right, Supervisor Ellenberg, we have a motion to receive the report. I am seconding that motion. Let me check with the clerk. Do we have any other public comment on this item?
We do not, sir.
We do not. All right, then without objection and hearing none, we have received the report under item number 6, and we'll move on to item number 7. What I'm going to do, however, at this point is just ask if we take a 5-minute break, let people get off the call, get on the call, take a bio break if they need to, and we will come back. Please keep your phone lines open, but we'll come back at 11:30 sharp and pick it up from there. All right? So we are stand in recess for the next 5 minutes. All right, thank you very much. This is Supervisors Sumitian back on. It's 11:30. Supervisor Ellenberg, are you still with us?
Sure am.
Thank you very much. Clerk of the Board, are you still with us?
Yes, sir.
Thank you. That takes us then to item number 7, which is receive the report relating to whole person care. Dr. Smith, to whom do we turn for this one?
Renee Santiago.
Yes, excuse me, Supervisor Ellenberg, yes?
Would you be willing to skip the presentation and go straight to questions on this item?
Sure. If that's your wish, given the length of our agenda and the time that was required for COVID, I think that's just fine. Do we go to Mr. Santiago for this one, Dr. Smith?
Yes, good morning. This is Renee Santiago. I'm here.
Thank you. Supervisor Ellenberg, why don't I go to you then?
Thank you. I actually don't have questions on this report, where my team is continuing to track this, and we'll monitor discussions going forward.
I guess the question I would ask, and thank you, Supervisor, is, Mr. Santiago, obviously the sort of bottom line question for all of us is, is the whole person care program actually leading to better health outcomes? And, the report looked at what I would call increased primary care and decreased inpatient days and emergency room visits. Wasn't entirely clear to me if that was compared to a control group of some sort. So what would you, what would you say with respect to, our ability to ascertain whether or not the program really has led to better health outcomes?
Yes, good morning, Mr. Chair and President. And obviously, in the report, we include the various partners and collaborations, as well as projects and initiatives that we're running under this program. One of the things that we're tracking is because there's so many different variety of strategies played out for a variety of different target populations. As you know, cumulative, we've enrolled 5,000 through the length of the program. Many of these projects are in midway in terms of the implementation. So that's why you're seeing most of the data related to utilization as well as enrollment and ED impacts in terms of visits. Ultimately, as you indicated, this is about better health. So that's going to take a while. One of the things that we are tracking is how many of these interventions are actually having that kind of impact. So one of the things that we rolled out from the very beginning as part of our consideration of this project is that we wanted to have what we call built-in sustainability. So we're hoping that at the end of this term, which is December 2020, over the 6 following months, we'll be in a better position to answer that question and to be able to answer it to the specific intervention. So, for example, if the peer-based Blackbird strategy is working very well for a very specific target population, we want to make sure we identify that so that we're more precise going forward in terms of what needs to be sustained. And then, of course, if there's other things that, even though they were promising, even though they were great ideas, even though they're very innovative, but we're not seeing the results that we set out to accomplish, then that's also important for us in terms of going forward. So we'll be in a better position to answer that question at the end of this project year, but be mindful that we are tracking at that level of specificity.
So we have both the report and what I'll call the PowerPoint. Not to overly simplify a lot of complex work, but if I were to bottom line it, Mr. Santiago, am I saying with respect to impact, too soon to tell, work in progress, initial signs encouraging, we'll know more in 6 months? Is that kind of...
Yes.
Is that a fair oversimplification? Let me try it that way.
No, that's a very good summary.
All right. Dr. Smith, your thoughts or comments on this? I'm curious to hear what you have to say about sort of where we're headed and what the potential or not may be in your view.
Well, I think it's a good program, and I think the preliminary indicators show that we're providing better quality in the sense that a big measure of quality of care is decreasing inpatient care and emergency care and increasing primary care. So I'll expect in the long term to see better outcomes.
All right, thank you. Supervisor Ellenberg, no other questions, I gather?
No other questions.
Then can we get a motion to receive the report, please, on item number 7?
So moved.
And second by Simidian, and confirming with the clerk, any speaker cards on this item?
None, sir.
All right, then without objection and hearing none, item 7 has been received, and we will move on then to item number 8, which is the Medi-Cal waiver. And do we turn to you again, Mr. Santiago, through Dr. Smith?
Yes, and thank you again. We have in the report pretty much an update that gives you a description of what's included in CalAIM. They went back to the original name. If you remember, they were switching back and forth. CalAIM still officially the name by the state of California in terms of this proposal. We also include an update on our progress on the 1115 waivers, as well as our strategic planning process. Of course, and duly, given the emergency and the critical nature of COVID-19 here in our community, as well as state and nationally, it's unknown to us what the state is planning to do relative to CalAIM. Just for your information, and this was alluded as part of the presentation on the COVID-19, we've been working very closely with not only other health officers in the Bay Area as well as statewide and nationally, but then also with our hospital partners, the California Hospital Association, to have California not only benefit from what's a different waiver, 1135. 1135 waiver grants a broad authority to the Secretary of Health and Human Services at the federal level to suspend a variety of different rules and regulations around Medi-Cal and Medicare. The state of California has a request. You might have heard in the press that the National Administration approved Florida for the first 1135 waiver. We're seeking one also for the state of California. A lot of work has gone into that to make sure that not only very specific rules and regulations around the administration of these programs are waived, but then also special consideration given the impact that it's having here locally as well as statewide. So we're tracking that very closely. We're also making the point at the state and federal levels that we're going to need additional flexibility related to 1115 waivers and 1915B waivers. Principally, we're looking for a 1-year extension. We've asked for that, given understandably our changing operating models and our care delivery models. We've had to redeploy staff to very specific functions related to our local emergency. So we're going to be seeking relief from some of the performance and quality improvement initiatives that are under existing 1115 waivers. That's has broad support at the state of California, so that's moving along in its way as well in terms of the federal process. And then locally, of course, besides the intense activity that's happening in the emergency, we're also delaying somewhat our strategic planning process. Nonetheless, what we're looking for is that we're looking for approval and come back to the full board. I think this is one of the things that you mentioned in terms of what are the things that we will need support or broad delegation authority. As you can imagine, our strategic planning process has been turned a little bit upside down. So we're looking for an amendment to the A&M consulting agreement. I just wanted to kind of note that for you because we do see that continuing not only into the next year, but then also engaging our partners once we do a reset, hopefully over the next several months, in terms of what are the things that we need to do on a sustainable path for what we're calling Transformation 2025. Again, a lot more details in the report, and I'm happy to answer any other questions.
Renee, can you clarify first, just a clarifying question, what's covered in the proposed 1135 waiver?
Yes, the 1135 waiver is principally covering a lot of emergency types of things. So, for example, I believe you heard earlier today about our medical staff in terms of the credentialing process. The 1135 gives the authority to the states to allow provider participation and credentialing on an expedited basis. It also allows for certain specific payment reforms you might have heard in the news in terms of the intent to allow for Medicare and Medicaid to pay not only for testing but also the care treatment. It gives some flexibility on the use of beds, which is very important as we implement or plan for surge. It also allows for telehealth, which I know it's been out there in the news, that we're already implementing under existing 1115 waiver, but of course we're using it now for a different purpose than prevention. So there's a series of administrative requirements for delays in cost reporting, delays and other kind of reporting requirements that also go alongside, but those are the major critical ones.
Thanks, I appreciate that.
Dr. Smith, anything you'd like to add before we go back to questions and comments from members of the committee?
Well, Dr. Smith is out of the room, but I could answer any questions you may have.
Great, then we'll focus there. Do I understand that we have someone from Santa Clara Family Health Plan available as well?
I see Tyler Haskell in the audience here. If you have some questions for him.
All right, good to know.
Okay.
Let me just ask, Mr. Santiago, are you, forgive me, I can't see or tell, are you in the room or are you?
Yes, I'm here in the dais, 6 feet apart from Dr. Smith's seating place.
Thank you very much. In looking at the report in our packet, I'm looking at page 2 of 4 in the report on this item, which for me is packet page 52. And in the last full paragraph where it talks about the state's CalAIM proposal, so on and so forth, at one point there's a sentence, I just want to make sure I understand who we're referring to here. It says the key principle of the CalAIM proposal is that a single entity working with multiple partners can best address the physical, behavioral, and social needs of individuals. What does that sentence mean, and who is the single entity we're talking about here?
Well, that's actually a very good question, and I'm glad you singled that out. This is in aligned also with one of the things that the state of California asked or laid out as part of this proposal. I think the principle is that one single entity that's responsible for not only the care but also taking on the financial risk is probably the one that is best positioned that can coordinate all the different elements. Of course, what the state is interpreting that to say is that they're encouraging at this point, they're not requiring, but they're encouraging, at least in this proposal, for Medi-Cal managed care plans to participate as part of Cover California. That's what they're describing as, quote unquote, the public option as currently proposed. Now, of course, for us here locally, this is not necessarily what we think as a public option. A public option, even nationally, is thought of very differently, depending, obviously, in the political aisles. But I think one of the things that the key principle still, I think, for us is very important, that there has to be a single entity that has both the responsibility and risk for the physical, behavioral, and social needs of this population. Because one of the things that we've learned, whether it be through whole person care or other strategies and initiatives, that if a healthcare institution or healthcare organization is only responsible for just very specific segments of the care, but not the total care or the total cost, that might yield good outcomes for that very specific process of care or that particular category of care. But ultimately, some of the most important determinants of health might be in the social realm. And the social realm, whether it be housing or food, nutrition, a variety of other things, are not necessarily the risk and responsibility of a managed care entity. So I think those are the kinds of things that still need to be discussed much more further in terms of what is the state plan at this point in time. But it's certainly from our perspective, and this is what we call in our strategic planning the community integrated health system, that I think our county is better positioned to be able to do all those things, given that not only do we have the relationships, the communications, as well as the partnerships, but we have such a vast safety net here in our county. So that's yet to be, as you know, articulated and further developed by the state of California, but it's included in their proposal.
Understood. Do we have someone from County Counsel's office on the line as well?
Yes, this is Douglas Press.
Hi, thanks, Mr. Press. Mr. Santiago, I understand Dr. Smith stepped away, but
He's back.
I'm back.
Thank you. Mr. Santiago, are we talking, when we're talking about the various partners, are we talking about our county health and hospital system and Valley Health Plan and the Santa Clara Family Health Plan and Anthem? Are those the folks that we're talking about in this case?
Well, we're talking about what we call the ecology of, quite honestly, not only in terms of our county government and all our partnerships, but also all the other resources that are in the community. The key is who is in the best position to not only take risk and responsibility, be able to coordinate all the different elements of it. And so certainly we're thinking we as a county, we're in the best position to do that, given our broad responsibilities here locally for the population. And therefore we made that case, quite frankly, to the state of California.
And what does that suggest vis-a-vis our relationship with Valley Health Plan, Anthem, and or Santa Clara Family Health Plan?
Well, right now we already have collaborative relationships, as you know. Valley Health Plan is already part of our county, so that's not an issue there. But even with Family Health Plan and Anthem Blue Cross, which is the private part of the Medi-Cal, we have collaborative relationships with both of them. We also have formal relationships, contractual relationships with both. As you know, we get delegated lives in our relationship with Family Health Plan. We also have fee-for-service formal contracts with Anthem Blue Cross. They have been part of the initiative for whole person care. For example, with Family Health Plan, we instituted the alternative placements for seniors primarily that are Medicare and Medi-Cal that need to be discharged from skilled nursing facilities so that hospitalized patients can move into the skilled nursing facilities. So we develop a pilot in partnership with them. So we think we're in a better position to be able to bring all the different facets together.
Hearing that, let me just say we had some conversation about this a couple of years ago, and there were a range of views between and among the board members and the staff. So, Mr. Press, Mr. Santiago, and Dr. Smith, I just want to be very explicit before we have any discussion of changing those relationships. That's a conversation that needs to be had very explicitly first at the Health and Hospital Committee and then subsequently at the full board. I just want to make sure that's clearly understood and agreeable. Yes?
Yes, absolutely. That's our plan. That's part of our outline in terms of the strategic planning process.
Dr. Smith, does that work from your standpoint?
I missed part of the conversation, but we continue to consider everybody partners, and we're trying to get on the same page of the playbook so that we can serve the system and the clients better. So any dramatic change would certainly come to the board to be discussed and, give direction.
Thank you. And I'm asking that it come first to our Health and Hospital Committee so that we have the opportunity to have a very thorough and robust discussion in that venue. Is that manageable as well?
Sure.
Okay.
Absolutely.
Thank you. Well, then, just to be clear, that's the expectation. I want to go on to page 3 of 4, which is packet page 53. And Mr. Santiago, in the first full paragraph, it says, the good news is that DHCS recognizes the success of whole person care, the global payment program, and parts of the coordinated care initiative pilots. This new proposal seeks to expand these programs to all Medi-Cal enrollees, not just those residing in pilot counties such as Santa Clara County. So we're talking, I think, about the state effort. As part of this effort, there will be major changes to Medi-Cal. These changes include, and then there were literally half a dozen bullet points. Are you following me here?
Yes, I do.
I guess my question would be, which of those half dozen bullet points strike you as most significant or important, and why? So, for example, it says standardized Medi-Cal benefit. That's a sort of a short, seemingly innocuous statement, but I can imagine that it would have quite a bit of impact given the the way we run our system, or am I over analyzing that particular phrase? Which of the half dozen do you think are significant and why? Let's try it that way.
Sure. I think there's at least 3 or 4 that are quite significant, if I may walk you through those.
Please.
One of them is, of course, the enhancing the care management and coordination. This is one of the specific areas that the state is asking at this point in time, in terms of at least proposing, to do as a result of providing sustainability to whole person care. They're asking for the Medi-Cal managed care plans to adopt this benefit, which is enhanced care management and coordination, in order to sustain those services and coordinate the care across the multiple providers for the most vulnerable populations. The second one is the in lieu of services, the implementation of lieu of services. This is related to the addressing the social determinants of health, which means housing, food, other kinds of things that are in some cases much more critically important to improving and stabilizing the health of individuals. So they're asking for managed care plans to identify what in lieu of services. We have a little bit of a concern because right now they're asking the Medi-Cal managed care plans to do this on a voluntary basis. We know from some of the data that there are very specific projects that are already having very good, promising results. That's indicated on the whole person care. So we're tracking that very closely. The aligning of the authorities is very important. This is the 1115 waiver and the 1915B coming under the 1915B authority. Not only in terms of just reducing the complexity and the financing of many of these public programs, but most importantly, integration of both medical behavioral health services for the target populations. I think this is specifically also relates to children, which, as you know, most of the 1115 waiver programs are related for adults. So this would be a much broader population, have much more broader implications, but I think it's an opportunity to not only integrate the services, but also ensure parity between the medical and the behavioral health services part of the house. And then the other one, which is the pilot programs. This is identifying counties or other entities that are willing to integrate physical, behavioral, and oral health services at a much higher level than ever before. And we've identified ourselves as one of the potential pilots if the state wants to go forward on these.
Thank you. Very, very helpful. And then the last question, I think this is a quick one. Looking at the second major paragraph on that page, there's a sentence that says it's anticipated that a revised document will be released by DHCS later this spring, perhaps early April. I think this is one of those cases where your earlier comment suggests that that date may now get moved as a result of the understandable need to focus on COVID-19 challenges, yes?
Correct.
All right, thank you. Supervisor Ellenberg, thank you for your patience. Do you have comments or questions on this item?
Thank you very much. It's another very sobering report and helpful to get the update on the Calian planning particularly. Renee, I just want to come back to while the state proposals are refined, I appreciate that we do have local planning underway, but I want to make sure again that the amended scope, before the amended scope comes back to the full board, I understand it's delayed now, will include the engagement of our external health system partners, including community clinics, FHP, as we've been talking about, Anthem and others, and a report to HHC on their recommendations and concerns as well. I believe I mentioned this in the first report back in August of 2019, the first report on T2025, but I want to reemphasize the importance of collaboration across all of our partners on this.
No, understood. Thank you.
Thank you very much. I'm happy to move approval of the report.
Thank you. We have a motion to receive the report, and I'm happy to second that. Let me first confirm with the clerk that we have no speakers on this item.
No speakers, sir.
All right. Then in the absence of anyone wishing to speak on the item, without objection, hearing none, the item is approved. That takes us to item number 9, RFP process and EMS updates. And Dr. Smith, how would you like to begin on this one?
We have Dr. Miller and Jackie Lowther here in the chambers to give you a report.
Okay, go right ahead.
Good morning, supervisors. If you would like just a very brief overview of the EMS 2022 report, we can do that, and then any questions.
I would like to ask that you go ahead and do that today. Thank you.
Okay, very, very brief, and then any questions that you may have, we'll be happy to answer for you. On the EMS 2022, we have been meeting. We've had 5 and another one, a Skype meeting on Friday to lay the groundwork for the group on the processes and opportunities that we'll have for laying out the groundwork. We're working now, we've gotten to the point that we have 2 working groups. One of these working groups is developing the scope of work and for the RFP. And the second one is working on the non-exclusive, whether or not we maintain non-exclusivity and what that actually means for the county, and if we have multiple providers providing services within our area. Throughout our meetings, we have gone over the backgrounds on Contra Costa and what that model looks like there, the financial summaries and financial implications for those providers that provide services within our county, legislative implications, what's happening in EMSA currently, and what our current position is pertaining to 1797-224. And because our EMSA, which is the EMS authority, is responsible for coordination and integration of all state activities regarding the EMS agency, and we have to always be mindful of that. And we have gone over the whole competitive process. So what we've done when we broke into those 2 groups, we took members from the EMS agency to oversee both working groups. They've had or will have had 2 meetings, and then our meeting on Friday, which will look essentially like this one, and then have report backs from both committees and see where we are next, because our hope, we're doing parallel processes, and then we will come back and report in May on where we are at that point in time. And that's sort of where we are on the EMS 2022 portion, and we'd love to entertain questions on any other portion of our report.
Thank you. Dr. Smith, anything you want to add before I turn first to Supervisor Ellenberg and then ask questions of my own?
Only that we're going to have to come to the board with lots of policy decisions about how we should proceed, because there's lots of options that are available to the board for decision making, and obviously will come through the Health and Hospital Committee first.
All right. Supervisor Ellenberg, comments, questions?
Not at this time, thank you.
Dr. Smith and Ms. Boswell, let me ask a couple questions. The report very delicately alludes to what was a sort of a frequent source of back and forth between local fire departments and our county at an earlier stage of these conversations. And I think, bluntly, Dr. Smith, there was some thinking on the part of some of the 15 cities and towns in our county that there might be some economic advantage to them participating in a way that hadn't previously been the case. And I think, if I may characterize your reaction to that, I would characterize it as skeptical. Is that a fair summary of where we've been?
Correct. The fire chiefs hired a consultant who tried to convince them that they would be able to bill Medi-Cal for extra fees if the program was run by the fire districts. That is, in my opinion, highly unlikely to be true. and upon research have shown that never in California has that been true in any EMS system, despite the fact that there is some legislation that alludes to that. And of course, in order to allow that to happen, it would have to be built into a 1115 waiver, and the feds would have to approve it. And as we've just been talking about, the feds are talking about reducing the cost of the 1115 waiver, not increasing it. So it's highly underlined with big bold letters, unlikely that there would be significant monies realized from having the fire system run the ambulance system. And on top of that, it would be far more expensive than the private sector.
At various times, we had some struggles around communication and concerns that folks weren't either informed or participating. And Ms. Lowther, are you feeling like if I were to pick up the phone and call, a dozen mayors and a dozen fire chiefs, if we have that many, they'd say, well, we may or may not like what we're hearing, but we are at least in the conversation?
Yes, sir, they are. We have a representative from the Fire Chiefs Association, the EMS Chiefs, the City Managers Association, and the Police Chiefs on the committee. Also the Hospital Council as well. So I think we have good representation on our committee.
All right. Well, I've got staff of mine who are on the call, of course, or on the, listening to the meeting, and I'm going to ask them to follow up with me to have us go do a little sampling here and there and just make sure that what we're hearing is the same thing. And to be clear, that's not because I want to second guess, but because I think you, Ms. Lowther, and certainly Dr. Smith with his history, and I and everybody will want to make sure we don't hear concerns or complaints 6 months, a year, or 2 years down the road. Better to know where people are right now than to have concerns raised at the 12th hour. So, we'll look forward to sort of working with you to confirm your understanding and experience on that, okay?
Absolutely.
Then on the stroke system update, thank you for that. My one, so let me just quite deliberately try and see if I can get a firm commitment here, Ms. Lowther. When are we going to see these numbers that we've not been getting on a timely basis, if I recall correctly, since, a year and a half ago now?
Yeah. So the system for registration for stroke patients within the 10 hospitals, the template has been created. We've begun to see early returns of outcomes from those hospitals. The timing is such that one of the key outcomes is one measured at a 90-day period post-discharge. So to capture the full picture of stroke outcome from clinical care, the timing will always be 1 quarter behind, meaning that the data from the previous quarter will be reported in the current quarter. That's beginning. We'll be able to look at a baseline or reassure, really, a baseline from the latter part of 2019, and then going forward into the first quarter of 2020 to look at some of the changes that should have occurred as a result of our change in protocol. Of course, we rely upon our hospitals in their engagement with us, and everyone is engaged with the current public health emergency. So I will temper my comments with saying that may modify somewhat of the expectations we set before.
And the one thing I want to probe on is, so we'll have that information by when?
We will have, we're aspiring to have our retrospective look for using this template for third quarter 2019 as sort of the attempt to verify that that template will perform as we expected. Then we'll be able to look, we certainly can know the consequences on patient volume to stroke centers from our pre-hospital data easily and readily. Identifying then the hospital discharge outcome data will take us into, for completeness, into second quarter 2020 to have a clear view of first quarter 2020.
Supervisor, for the time frame, because our reports are due the end of March for the April HHC, we will have a definitive report for you for May, just due to timing, and we will get that. I think it's the end of May report. You will have a comprehensive stroke report at that time.
All right, let me try it again. It's March 18th today.
Right.
By when do I get the first report, which I understand is now going to be for the third quarter of 19, yes?
That's correct for the purposes of validating the template.
Okay. When is somebody going to say, here it is? Today is March 18th. We're talking about data from the third quarter, which means that if we were to get it by the end of March, it would already be 6 to 9 months old. And I understand that that's because that's going to be your baseline. And my question is, when are we going to have that? And the reason I'm pressing is because I've been asking these questions politely for a year and a half, and we have had continued delay.
We have vision on our stroke system. So it's the conveyance of the requested data that is in question, and I believe that we will have enough to convey that with the May presentation that Jackie just talked about.
Give me a date, please, on the calendar. 365 days in a year. Give me a date.
I'm checking on the dates for the meetings now.
Are you telling me we're not going to have this information available for either the public or the committee or the Stroke Foundation until sometime in May, at which point it will be almost a year old?
To the question of the Stroke Foundation, their particular interests are largely demographic, and once we have validated the performance of the template from the hospitals, we will know the particular data they are looking for. We are looking for far more comprehensive data than that goes to imaging, that goes to neurological function and performance post-discharge. So the accumulation of that data will take a little longer than what the Stroke Foundation is looking for.
Again, I'm looking for a date. This is, I believe, the third, fourth, or fifth time today I've asked the question.
So in trying to coordinate these various questions, it looks as though for the purposes of demographics for the Stroke Foundation, April should be achievable.
April includes 30 days, so that means by April the 30th, yes?
Yeah, it would.
And then for the broader analysis that you indicated earlier, that will be ready by when?
We're looking at the dates for the next meeting for HHC. So if May 26 is the date for this meeting, then that should be our goal.
Okay. And so I'm taking that to mean that at today's meeting you've indicated April 30th for the demographic data that the Stroke Foundation has requested, and May 26th for the broader analysis that we have all requested and need to do our planning and protocol implementation, yes?
I think that'll work.
Okay. Dr. Smith, just for the record, I have found this a frustrating exercise in getting important information. I consider it an unacceptable response from county staff, and we can't make thoughtful policy judgments or implementation decisions if we don't have the data that is the necessary precondition for that. Just putting it on the record. That takes us then to compliance, contract ambulance performance, and first responder compliance. I'm going to do this slightly reverse order. By looking at first responder compliance, I'm looking at the chart on page 4 or 5, packet page 75. San Jose appears to be hitting its mark on all of these months. Is that a correct reading?
Yes, it is, sir.
Thank you. Well, that's a a significant accomplishment over these last several years. So, that's something we should pause and say good all around. And then as I look at that same chart, it would appear if 90% or better is still our threshold, which I believe it is and is indicated in the paragraph under first responder compliance, that everybody's making their mark and has done over the 7 months that are represented in the chart, yes?
Yes, sir.
Okay. Then going back up to the contract ambulance performance, could you walk us through this a little bit, please? Looking at the chart, thank you for the highlight in red, which helps make those 2 months pop out. So where are we now that we've had the back and forth? And thank you for trying to run this one to ground. Where are we on the determination as to whether or not we have or have not had 90+% compliance? Could someone walk us through that, please?
We have settled on, and this graph is on the previous methodology we used prior to the 7th Amendment, and they have made greater than 90% since that October 2019 little blip. Using the previous methodology, we couldn't come to consensus on that, and it was too confusing to be showing both. So we have settled on using prior methodology. We are currently, as stated, working on the 8th Amendment and should have that completed sometime in April, but maybe by the next HHC. I had stated by the end of April, April 30th as our target date. So this here is our previous methodology. We're not even looking at the 7th Amendment methodology anymore. We've instructed First Watch, which is our...
Ms. Lowther, excuse the interruption.
Yes, sir.
That when you say previous methodology or prior methodology, of course, it means, to me, I'm thinking previous. There's a lot of history here, so I want to make sure I know previous what. Is this the methodology that we were using, let's say, 5 years ago when you say previous methodology?
Prior to the 7th Amendment, prior to...
Right. And it was the 7th Amendment that changed the way that we allowed the contractor to calculate on-time compliance, yes?
Yes, sir.
Okay. So if you're me and you have a fondness for the old methodology, you say we're doing it the good old-fashioned way that before we got into the numbers from the 7th Amendment that caused concern at the committee. Have I, understanding that I've editorialized there a little, have I got that right?
Yes, sir. 2 years ago.
Okay. And did I understand you then to say that going forward, November 19th going forward, we're going to use that older methodology, not the methodology that was in the 7th Amendment, yes?
Yes, sir.
And in the 8th Amendment, are we then adopting or re-adopting the older methodology? Is that what's happening?
Yes, sir.
Okay. Thank you. That answers my questions. I didn't mean to cut you off. I wanted to make sure, though, that I was understanding what you were sharing. Anything else there that you would like to provide?
No, everything there, I hope, is clear.
Okay. Dr. Smith, back to you, please.
Yes.
Anything else you want to make sure we understand? And then I'm going to go to Supervisor Ellenberg to see if she's got closing comments or questions, and if not, a motion.
No, I think they went through it unless you have questions of me.
I'm good for the moment. Supervisor Ellenberg?
Glad to move acceptance of this report.
All right. So the recommended action is to receive the report from EMS. And we have a motion from Ellenberg, a second by Smidian. Let me check with the clerk. Anyone who is wanting to speak on this item, clerk?
No speaker cards, sir.
Thank you very much. And without objection, hearing none, item 9 is approved. The report has been deemed received. That then takes us to item number 10, and we have a lot of, I'll call them subparts to this item, and I am guessing that not every one of our usual participants is available on this. And of course, we heard at length earlier from public health. So, Mr. Santiago, why don't I ask you to walk us through A, B, C, D, E, F, G, and H, and if someone's simply not available today, we'll pass, and if it's already been heard, we'll so note. But I do want to give the opportunity to present on items where we've not yet heard from somebody and where they are able to be present with us either telephonically or in the room. So go to it.
Yes, and in the interest of time, I think what we'll do is we'll just take any questions if you have from any other departments. The reports are submitted accordingly. I just wanted to highlight a couple things that have come up before. I gave you an update in terms of the administrative regulatory track. They had some questions about MFAR and some of the other things that are happening at the federal level. We have an update here legislatively, but also one of the things we're tracking as part of the stimulus packages that are being put together in response to COVID-19 includes suspension of MFAR. It's kind of a directive, at least at this point in time, from the House to the federal administration. It also includes an adjustment on what we call the federal Medicaid participation rate. That's very important for us because that gives us direct Medi-Cal reimbursement that will help mitigate some of the loss in revenue as a result of the emergency, as well as a variety of other benefits, of course, that are targeted for individuals in terms of supplemental safety net packages, whether it be covering unemployment insurance, extensions of benefits for certain populations, et cetera, et cetera. So we're tracking that legislative very closely and working with Bert Margolin and the team. He's not available today, but obviously they're also doing that in our behalf. The other second piece that I wanted to highlight for you is something that you've been interested. We gave a little bit more details and status. What we're calling our healthcare access program, which would provide medically necessary care to all those below 400% of federal poverty level. We include detailed information in my report related to our current work that we're working closely with not only all the other departments, but also in terms of county council. And we hope to have that policy coming up for your consideration in April. So that will end the presentation unless you have any specific questions of any of the items.
Thank you. I will just focus on two items briefly. The first is thank you for the somewhat greater detail on the effort. I'll characterize it as the effort to expand healthcare access. I think while I've tried to highlight it, I think it's consistent with expressions of interest and concern from all 5 board members over the years and sort of central to what we do at the county. I appreciate the effort, and we'll keep working with you to make that real. The other question I wanted to ask about was we have been working to see if we cannot both expand the efforts of our Better Health Pharmacy, but more specifically on a referral that I submitted, a request to see if we could find a way to provide free or subsidized medication for specific life-essential, high-cost drugs. That was a referral that I think Mr. Lorenz and Mr. Press were working on. Can we get some feedback on that one, folks?
Yes, I think our plan is to come back in April with the very specifics. Of course, this is depending how this COVID-19 unfolds over the next weeks, but that was our intent. If anything changes, we'll communicate it to you in an off-agenda memo in between meetings.
All right. Mr. Lorenz, Mr. Press, any further comment on this?
No, this is Douglas Press. Other than just to state the obvious, we're the County Council's office is devoting an enormous amount of its resources to all aspects of the COVID-19 response. So we're doing our best as far as ongoing initiatives.
Got it. That being said, the healthcare needs of the folks we're talking about in the referral are ongoing as well. So appreciate everybody's best efforts to manage a high volume at a particular time, and want to make sure this one gets addressed. Why don't I turn to Ms. Ellenberg, see if you've got questions on any of these various items, A, B, C, D, E, F, G, H.
No, I'm good.
All right.
Thanks very much. I won't ask questions at this time.
All right, then. Dr. Smith, anything else you want to share with us on any of these items? Mr. Santiago?
No, I'm fine.
We're good.
All right. Mr. Santiago, want to make sure I don't miss you just because you're not literally sitting in front of me today?
No, it's perfectly fine with me. Thank you very much for your leadership on this.
Then let me just ask. If we can get a motion from Supervisor Ellenberg to receive the reports contained under item number 10.
So moved.
We have a motion by Ellenberg and a second by the committee, and let me confirm with the clerk there are no cards on this item. Nobody wishing to speak?
No cards, sir.
Thank you. That, with that in mind, then without objection and hearing none, item 10 is unanimously approved. Supervisor Ellenberg, unless there's anything else, we have covered our consent calendar earlier. I believe that means we are ready to adjourn. Have I missed anything on your list today?
No, you haven't. I am happy to move and adjourn.
All right, Dr. Smith, we have a motion to adjourn. Any reason we can't say without objection we are adjourned?
No reason.
All right. Thank you, everybody, for helping and participating during what I know is a very challenging time. Thank you for all the work you're doing. Without objection and hearing none, we are adjourned. We will next meet on April 29. Be well.
Thank you very much, everyone.